Before we start, is there anybody here who did a radicular syndrome masterclass?
Než začneme, je tu prosím někdo, kdo byl na masterclass o radikulárním syndromu? Pokud ano, ruku vzhůru, prosím.
Okay. So you may go now.
Aha. Tak vy už to znáte.
We're going to do some different stuff. We're going to talk about radicular syndrome. That's why you signed up, I guess. And we're going to talk about when a derangement is not a derangement. And the reason why I put it this way is that what I feel with a lot of McKenzie people, they keep searching for centralization and sometimes it's just not there. Mm-hmm. And we have to decide when to stop that. Mm-hmm. Right?
Tak, dnes nás tady společně čeká téma radikulárního syndromu, to je taky asi důvod, proč jste se zapsali na tenhle ten workshop, takže to je naše dnešní téma. Vidíte, že tu prezentaci jsem pojmenoval, kdy derangement není derangement. Rozhodl jsem se pro tenhle název proto, že spousta fyzioterapeutů, kteří pracují s McKenzie metodou, vlastně velmi často ztrácí spoustu času tím, že pořád hledá tu centralizaci, spálí na tom spoustu sezení a ona tam prostě není. Takže bych se rád zaměřil na to, kdy vlastně jsou tam indikátory pro to, abychom hledat přestali a začali z nějakého jiného konce.
Unbelievable, isn't it? I never could do that. The other thing is that we sometimes, if you have a radicular syndrome and it's really inflamed, maybe it's not so clever to do exercise, right? And we as physical therapists, we always want to do something, but sometimes is doing nothing really the right choice. Okay, so I want to try to cover a bit on that two items.
Další takové klíčové sdělení té mojí dnešní prezentace je, že pokud máme pacienta s radikulárním syndromem, kde je zároveň přítomný vysoký zánět, tak někdy možná není úplně nejlepší způsob práce s ním cvičit. A to samozřejmě pro nás fyzioterapeuty je někdy poměrně problematické, protože chceme něco dělat, chceme nějakým způsobem intervenovat, ale někdy je možná lepší nedělat nic. A to bych vám dneska rád v rámci té prezentace předal.
Okay. Who is already familiar with this classification, new classification system?
Už zná tenhle nový systém klasifikace, kdo už to viděl?
All right, so not that many. I will go over it quickly because it's outside this workshop, but just very quickly. We first, of course, we try to exclude serious pathology.
Tak vidím, že vás tolik není, takže to rychle proběhnu, abychom měli kontext pro ten dnešní workshop. Jak vidíte, začíná to zase stejně, to znamená, v první řadě je potřeba vyloučit jakékoliv závažné patologie.
Being those patients who really send away immediately from your clinic.
To znamená vyřadit si vlastně ty pacienty, které rovnou na tom prvním sezení ve vaší klinice pošlete někam jinam k nějakému příslušnému odborníkovi.
If we go back to radicular syndrome, which two classes of patients we would send away immediately.
Když se bavíme o tom radikulárním syndromu, jaké typy pacientů vlastně hned v té první fáze odešleme někam jinam? Kteří to budou? Napadne vás?
Thinking about radicular syndrome, which patients would you think, well, I need to send this off to the hospital? Když si
představíte pacienta, který přijde s podezřením na radikulární syndrom, u kterého si řeknete, tak toho musím okamžitě někam poslat. For example, paresis.
Paresis, and which paresis do you talk about then?
A severe one, he says.
Cauda syndrome, but also in paresis. But when do you decide, well, this patient has to go off very quickly?
V jakou chvíli si to řekneme? Když si řekneme, tak tohohle pacienta okamžitě odesílám pryč, protože ABC.
Yeah, cauda is one of those. But if I have weakness,
somebody says.
Yeah, so that's all cauda stuff,
to je všechno vlastně součástí tohohle souboru.
If you have weakness, which weakness figure would you send away from your clinic?
Jakou intenzitu té slabosti už budeme považovat za indikátor k tomu, že toho pacienta pošleme někam pryč?
Do you use 0 to 5?
Využíváte takové to měření 0 až 5?
So under which number do you think,
tak
I need to be
u kterého toho čísla si řekneme tady pozor, tady to možná bude chtít nějakou jinou intervenci. 2 and more, somebody says. 2 plus, slyším dobře? 2 and more.
Yeah, I would say less. Yeah, it's actually under 3, right? If you find under 3, then the next question is very important, is how long do you have this?
Takže pokud bude vlastně ta intenzita pod 3, tak další důležitá otázka je, jak dlouho už to trvá.
Because if I walk like this for a month,
protože jestli takhle už chodím měsíc,
then I don't need to do surgery because it's not going to help for that.
Tak mi asi operace moc nepomůže.
But if I just found out that this is for a day or 2 days, then you should be quick, right? So everything in the tree should be sent in very quickly, otherwise you're too late with your surgery to have an influence with surgery on that weakness.
Ale pokud to trvá třeba jenom 1-2 dny, tak je potřeba jednat. Je tam potřeba skutečně ten rychlý zásah, takže ve chvíli, kdy je to pod 3 a trvá to velmi krátce, ty symptomy, tak je potřeba odeslat pacienta někam dál, protože v tu chvíli ta operace skutečně pomoct může.
And often it's related to progressive weakness as well.
A také to může být ve spojitosti s progresivní slabostí.
And I saw last week I had a patient who came on Monday and he was having like 3 plus, it was a little bit more than 3, but at the end of the week he phoned me, he said, well, it's getting less and less and less. So I asked him in and he only had 2 left. So I sent him in immediately and he got his surgery, which I was happy with because normally you need to have the name Queen Maxima or something like that in my country to get that quick surgery.
Já jsem třeba zrovna minulý týden měl pacienta, který přišel v pondělí a udával trošku přes 3, kolem 3, takže jsme to nechali být, ale koncem týdne říkal, začíná se to hodně snižovat, takže jsem si ho pozval znovu a pak už jsem ho rovnou na tu operaci odeslal, protože jsem viděl, že to je přesně tenhle ten případ, kde ta operace skutečně může pomoct.
So, back to the classification system. We have one classification now new, which is a medical condition. A medical condition is that situation where you don't need to refer like immediately, but there is a medical condition where they should take care of.
Tak, zpátky k té naší klasifikaci, jak to funguje. Pod tou závažnou patologií vidíte, že máme onemocnění vyžadující lékaře, neboli medical condition v té anglické terminologii. A to je takový stav, kdy vlastně ten pacient nevyžaduje tu intervenci dalšího odborníka hned v tu danou chvíli okamžitě, jako v tom prvním případě, ale je možné, že tam bude potřeba toho lékaře přizvat.
Well, you can think about a patient who has signs of diabetes, so they do a few press-ups and they start and they are thirsty and they need to go to the toilet and they sweating and like that, and you think, well, there's something going on here. Maybe I send it off to the general practitioner to test the blood and see if there's diabetes underneath.
Tady si představme třeba pacienta, který přijde, je třeba trošku obézní, má nadváhu, vy s ním začnete cvičit a on se vám rychle zadýchá, najednou má žízeň, začne se potit, musí si dojít na záchod. Tak v tuhletu chvíli, kdy vy pojmete nějaké podezření třeba na ten diabetes, tak si řeknete, dobře, tak tady by bylo možná dobré kontaktovat všeobecného lékaře, aby provedl případně nějaké testy.
So then the next one is derangement, and that's on top of our classification system because that's interfering with other classifications, like in radicular syndrome. Could be a derangement, maybe it's not a derangement. In central canal stenosis, could be derangement, maybe it's not a derangement.
A jak vidíte, na vrcholku té klasifikace máme ještě derangement a je umístěna takto na vrchu, protože pak ovlivňuje řadu těch dalších rozhodnutí. Třeba u radikulárního syndromu můžeme mít derangement, ale nemusíme a podobně u dalších obtíží.
Where we had in the old system, we had derangement, dysfunction, postural, and then we had the others. And we sort of talked a bit about the others somewhere in the part C and D course, maybe. And now we said, well, we can recognize them, we can classify them, we can examine them, and sometimes we have a really good way in the McKenzie way to deal with those classifications. So we put them on the classification system as single items.
Možná si vybavíte, že v té předešlé klasifikaci to bylo vlastně tak, že tam byl ten derangement, dysfunkce, posturální problémy a pak taková sběrná kategorie ostatní. Těm se trošku věnujeme těmhletem obtížím v těch kurzech CD, ale vlastně ne tolik. A smyslem téhleté nové klasifikace je vlastně podchytit to separovaně, protože velmi často se to dá hezky klasifikovat, dá se to vlastně i docela dobře terapeuticky řešit a často i ta metoda McKenzie nabízí docela pěkné terapeutické možnosti.
So a few of those other classifications have got a different name. So dysfunction is now articular dysfunction.
A vidíte, že některé z těch dlaždic, z těch skupin těch problémů jsou teď trochu přejmenované. Třeba to, čemu se dřív říkalo jenom dysfunkce, je teď artikulární dysfunkce.
In the earlier days we said mechanical inconclusive. We call that now atypical mechanical condition or syndrome.
V té druhé skupině, které se teď říká atypický mechanický syndrom, jsme dříve říkali mechanicky blíže neurčený, takže to je zase trochu jiné pojmenování.
And now we go to the radicular syndrome, where it's circled. In the old days, it was mechanical unresponsive radicular syndrome, MUR, which was a nice abbreviation. And now we call it radicular syndrome without directional preference.
A pak tam je ještě jedna změna, to je to další červené kolečko, co vidíte, to, čemu se teď říká radikulární syndrom bez směrové preference, byl dříve mechanický responsibilní radikulární syndrom.
Over there. And the reason for that is that while teaching mechanical unresponsive radicular syndrome was often that people who didn't speak English, they understood unresponsive as being no effect in repeated movement testing, which is not true. You can have no better, no worse, no effect. But people thought, well, if a radicular syndrome is an MUR, we shouldn't change anything during repeated movement testing because we translate, at least I did as well, translating unresponsive to nothing is happening, which is not true. We didn't find centralization or directional preference.
Ten důvod toho přejmenování je, že když se to dřív jmenovalo mechanický neresponsibilní radikulární syndrom, tak vlastně lidé, zejména ti, kteří třeba úplně nevládnou angličtinu, měli za to, že to neresponsibilní tady znamená, že ty obtíže vlastně nereagují na to testování pomocí opakovaných pohybů a že se tam v podstatě nic neděje. Ale to není úplně ono, protože tady je pořád důležité určit, jestli tam centralizace po případě směrová preference jsou nebo nejsou. Takže proto to přejmenování, aby to neresponsibilní nebylo vlastně zavádějící.
Right? So, and now it's important because if we look at the radicular syndrome, it could be a derangement, but it can be a radicular syndrome without directional preference. So there we really need to split. And we use a new algorithm for that. And sorry for the letters not inside the boxes. Look at my slide. It's the same slide. It's beautiful, clean, and so something went wrong in the technique here.
Takže pokud je o ten radikulární syndrom, tak vidíte, že tam pořád je potřeba určit, jestli je to ten s derangementem, anebo bez směrové preference. Tady se trošku omlouvám, že nám ty nápisy úplně nesedí do těch dlaždiček, ale jak vidíte, já jsem to měl anglicky správně, takže chyba není na mé straně.
I will ask Eva to send you the nice
Poprosím Evu, aby vám to
okay?
poslala, tak abyste to měli hezky.
So, but where's it all about? We do a history, we take a history, and we test range of motion, and then, of course, in the history we hear leg symptoms, arm symptoms, which need neurological examination. So you do your neurological examination, and in your neurological examination, if you find positive findings, then you should start to think this is a radicular syndrome.
Takže začínáme jako obvykle, uděláme si anamnézu, otestujeme rozsah pohybu, budeme vyšetřovat nohy, ruce, tam se nám mohou objevit symptomy, které budou vést tomu neurologickému vyšetření, respektive k potřebě toho neurologického vyšetření. A ve chvíli, kdy máme pozitivní neurologický nález, tak je možné začít uvažovat o tom radikulárním syndromu.
And then the beauty of MDT is that we start to do our repeated movement testing, and we're going to find out if this patient is centralizing his pain or not. To make that split between derangement and radicular syndrome without directional preference.
A krása MDT spočívá v tom, že začneme testovat pomocí opakovaných pohybů a díváme se, jestli pacient centralizuje nebo ne. A to nám vlastně pomůže rozlišit mezi derangementem a mezi radikulárním syndromem bez směrové preference.
Do we need to do that in one visit?
Myslíte, že to je potřeba zvládnout všechno během jednoho sezení? Že na konci prvního sezení už musíte mít závěr? No.
No. Well answered.
Přesně tak.
Beautiful. No, you can use like 2-3 visits for that, right?
Přesně tak, můžete si na to dát 2-3 sezení, není to vůbec problém.
But you have to realize that sometimes it's over. It's not centralizing. And maybe that's the most difficult part, to make that decision.
Nicméně je také důležité umět v určitém bodě přestat a říci, že tam ta centralizace skutečně není. A to je někdy těžké, vědět, kdy s tím testováním vlastně skončit a dojít k tomu negativnímu závěru.
Okay. And then if we have a radicular syndrome without directional preference, but also in derangement, does it sound like inflammation or not? Do we need to exercise on it, or do we need to back off a bit?
No a ve chvíli, kdy k tomuto závěru dojdeme, tak si musíme říct, jestli to vypadá, že je tam přítomen zánět. Protože ve chvíli, kdy je tam zánět, tak je to spíše indikace, protože bychom s tím cvičením měli trošku přestat, malinko zvolnit, kdežto pokud tam ten zánět není, tak můžeme hrdě cvičit.
In other words, is it highly reactive or low reactive?
To znamená, pokud je otázka, jestli je to tedy vysoce responsibilní nebo nízce.
So you all get now a assessment form of Kate, at least 1 and 2.
Tak, vy byste teď měli všichni nebo minimálně do dvojic dostat anamnézu nebo evaluační dotazník pacientky Kate.
And what I would like you to do is look at Kate and see what classification she is.
A já bych teď chtěla, abyste se na ní podívali a zkusili podle té naší klasifikace odhadnout, kam tam bude spadat.
Give me the half of it.
Polovinu, prosím.
Just go on.
Careful.
Thanks.
Can you do one per two people? Going well?
Yep.
Good. So, and if you think about the classification, I would like you to think about how sure you are about your classification.
Tak a jestli už potom dojdete k nějakému tomu zařazení a budete mít nějakou představu o tom, kam teda Kate spadá, tak by mě zajímalo, do jaké míry jste si tím závěrem jisti. V procentech třeba.
Or in other words, are there any things where you think, well, I would expect this to be different?
Should they go through the whole material or only the first page?
No, the whole
Cokoliv
thing.
tam najdete. A pokud třeba dojdete k nějaké té diagnoze, k nějakému tomu závěru, tak by mě taky zajímalo, jestli jsou tam třeba nějaké věci, u kterých si říkáte, no tak není to úplně typické, tohle spíš možná nasvědčuje něčemu jinému. Takže
Is anyone left out without a which?
Dostal se prosím na všechny, nebo někdo nemá handout? Aspoň do dvojice.
Right.
Seems like everybody got
Yeah,
one.
good. Till what time?
Let me think, I didn't check. We started, I think, till 6 p.m., if I'm not mistaken.
Yeah, something. Okay. Do we still have Kate? Do you want to have her? There are some leftovers. There are some leftovers. If you run one. Do you have it? Right, so what do you think about the classification?
Tak, co na to prosím říkáte z pohledu té klasifikace, jak jsme viděli na tom předchozím?
In the other workshop, everybody was wrong. So what do you think about the
V
classification?
minulé skupině to nikdo neuhodl, tak co si
No, that's a
myslíte
joke.
vy? To byl vtip.
What would it be?
Tak, co vy na to? Někdo nějaký nápad?
Jeví se to jako derangement.
It seems like derangement. There's no symptomatic answer.
Podle
So according to the symptomatic answer, it seems like derangement, but given the mechanical response, we don't know yet.
Right. So is everybody agreeing that this looks like a derangement?
Přesně. Souhlasí všichni, že to vypadá na
No.
derangement?
So, and if I talk about how sure are you?
A kdybyste měli říct, na kolik procent jste si jistí? 50, somebody says.
60.
50.
50% only.
Jenom 50%.
No, so
75?
it's a derangement, but
75, somebody says.
yeah, that's
Yeah,
more
different
likely. But the thing you miss is maybe, as you said, the mechanical response is 0. And what's the mechanical response here?
Tak je tam ale problém s tou mechanickou reakcí.
Where
jak
do
jsme
we
říkali.
look at if we talk about mechanical
Na
response?
co se budeme dívat, pokud se bavíme o té mechanické reakci?
Chceme zlepšit rozsah pohybu.
We want to increase the range of motion.
Yeah, so it's range of motion and
Přesně tak, takže rozsah pohybu a co ještě?
neurology, right?
Neuro, přesně.
And one other mechanical baseline is acute deformity.
A případně také nějaké akutní deformity.
Well, this is not in this case, but
To není ten případ,
if
ale
we
patří
say
to.
no mechanical response or no effect on the mechanical response, it meant to be here range of motion and neurology, right? So that's good that you saw that because it's important to keep an eye on.
Tak, pokud řekneme bez mechanické reakce nebo bez dopadu na mechanickou reakci, tak tím myslíme jednak rozsah pohybu a jednak tu neurologickou složku. Takže je prima, že jste si toho všimli, to je určitě důležité na to pamatovat.
So Kay did her exercises and she was sitting with her rolls. She was not good in that. Sometimes she just forgot it, but sometimes she got a little bit more back pain or leg pain from it. And she said she didn't like it. She's now disappointed because she did her exercises nicely and in time, and she tried to do her best, but it didn't give her the same response anymore.
Tak, Kate přichází na kontrolu a referuje tedy, že doma cvičila tak, jak jí to bylo zadáno, seděla s válečkem, někdy na to zapomněla nebo udává, že jí to úplně nevyhovovalo. Nicméně je trošku zklamaná, protože to na ní nemělo stejný efekt jako při té první kontrole u vás.
So she showed me how to do extension in lying, and now she's decreasing her calf pain and increasing back pain, but it's now no better. So remember, the first day it was getting better. Now it's getting no better.
Tak, předvedeme extenzi v lehu a říká tedy, že bolest v lýtku se snižuje, naopak bolest v zádech se trochu zvyšuje a důležité je, že tady není zlepšení, není lepší, zatímco během té první návštěvy lepší bylo.
And again, no range of motion differences and no neurological differences.
Opět žádné rozdíly v rozsahu pohybu a v neuro.
So what's your diagnosis today?
Co diagnostikujete dnes na této kontrole?
What's your classification today?
Still
maybe derangement? Is everybody agreeing?
Klasifikace je pořád asi derangement, souhlasí všichni?
Yeah, so you would go lateral, okay?
Začala z laterální.
And if I'm a very McKenzioid person,
a pokud jsem McKenzie
you would do a progression. If you go lateral, it's alternative, right? Okay, you would do a progression.
Dobře, takže progrese.
So, I want you to keep an eye on those two things. Yesterday it was better. Now I do the same and I get less, no better. And there is no range of motion difference and no neurological difference.
Tady bych chtěla, abyste se zaměřili na to, že když jsme to dělali na té první návštěvě, tak se mi zlepšila. Teď děláme to samé, ale je to bez zlepšení a zároveň tam pořád není žádný rozdíl v rozsahu pohybu ani v neurologii.
So we want to do a force progression. What would you like to test?
Tak, uděláme si progresi. Co ještě?
What would be the next progression?
Potřeba otestovat, co bude další progrese.
She did extension in lying.
Udělali jsme leh, tak teď je na řadě. Without breath and with overpressure.
Yeah, so patient overpressure and maybe therapist overpressure.
Takže pacient před tlaku a terapeut před tlaku, dobře.
And according to this info, what do you need to educate as well?
A když se vezmeme tyhle informace,
have a look at?
Tak co je potřeba pacientce říct, nebo co je potřeba v čem edukovat, prosím? Maybe correction in
Yeah,
sitting.
so have a look at that sitting. Maybe
Přesně,
she's not using her lumbar roll very correctly or whatever,
Je
right?
tam možnost, že třeba nepoužívala ten váleček úplně správně, je to potřeba
Or she's sitting too long, so maybe she could sit shorter. So you have to look at that maintenance of the derangement.
Nebo možná sedí moc dlouho, takže nějakým způsobem upravit toto.
So we went from derangement 75% to maybe derangement 60%. Something like that?
Z derangementu na 75% pravděpodobnosti jsme se dostali k asi derangementu.
Okay.
Je to tak?
So we did therapist overpressure, patient overpressure.
Takže dělali jsme přetlak pacienta i překlad fyzioterapeuta.
And now she got a decrease of calf pain, increase of back pain, and felt better afterwards, but no effect on range of motion and neurology.
Tak teď se nám zlepšila nebo snížila bolest v lýtku a zvýšila bolest v zádech. Cítila se potom trošku lépe, ale pořád to nemá žádný vliv na rozsah pohybu ani na neurologické příznaky.
What's your diagnosis?
Jakou diagnostiku nebo diagnózu máme teď?
Well, I think it's derangement again because it got better.
Zlepšilo se to, takže derangement.
Did she centralize her pain or?
Byla tam centralizace?
Yes?
Yes.
Okay. Who's credentialed here? Who is credentialed therapist?
Kdo je credential therapist?
No, that's nasty to
Asi
ask.
certifikovaný.
Is it centralized or not? No, it's not. Why is it not centralized?
The pain didn't go away.
She only decreased calf pain. It didn't abolish, so it didn't go away, right? Doesn't matter that. It's just to pinpoint a bit on the definitions. So how do we call this?
Bolest lípku nám neustala, jenom se nám snížila, to je ten důvod. Jak se tomu říká?
A directional preference, right?
Směrová
Coupled
preference.
to derangement, so still it's okay. Ale, that's my only check I can, I think. I always forget how was good morning because I ask that always when I'm here. But ale, I remember.
Ale z good one.
Again, you gave more pressure. And she comes back with less, right? I want you to keep an eye on that.
Tady zase vidíme, že jsme vlastně přidali na tom tlaku, ale ten výsledek je slabší. Jo, to je důležitý poznatek.
Well, she doesn't get less yet. But so we sent her home with what?
Tak, pacientku posíláme domů s čím? We could still try lateral.
Yeah, but now we got better. So do we need to try
Ale
lateral?
zlepšila se nám, takže možná teď je otázka, jestli je potřeba zkoušet laterálně.
Posíláme s přetlakem domů.
No, just progression and overpressure.
Yeah, so what would be the home exercise?
takže
We
to je
did
cvičení
patient
na doma.
overpressure, therapist overpressure.
Dělali jsme přetlak pacienta a terapeuta. A co bude pacientka dělat doma? Overpressure.
Yeah, but I went into therapist overpressure.
Ale dělali jsme přetlak
You do
terapeuta.
that with a reason. When do you go from patient overpressure to therapist overpressure?
Jdeme nejdřív z pacienta na terapeuta. Aha. Yeah, with belt, right?
Yeah, so you do it with belt. Send her home with repeated extension in lying with belt.
Přesně, takže opakované extenze v lehu s páskem.
Okay. So now she comes back and no change in pain intensity or location and no change in neurological and range of motion.
Tak, Kate se nám vrací po třetí a opět bez změny v lokalitě a intenzitě bolesti a bez změny neurologických příznaků a rozsahu pohybu.
So I look at her, do extension lying with belt fixation, see how she does it. She does everything right, but there is no change in symptoms anymore.
Takže si ji položím, ona mi předvede, jak provádí ty extenze v lehu s tím páskem, dělá to všechno správně, nicméně máme to bez změny. Co teď?
Diagnosis.
Jaká je diagnóza? I would try some alternatives of the progression.
Is there anything else you can do in the sagittal plane?
Dá se dělat ještě něco v sagitální rovině? Mobilization.
Mobilization, extension mobilization. That would be your last step,
To by
right?
byl poslední krok, přesně tak, mobilizace.
But that doesn't say how we call her. What's the classification?
Tak, a co ta klasifikace?
Derangement, maybe derangement, could be derangement.
Tak, derangement, asi
We are now
derangement,
in
možná
could
derangement, třeba asi
be a
eventuálně možná
derangement, all right? But we have to test extension, mobilization, and we have to test a lateral.
Takže
maybe,
musíme
if
otestovat
extension
extenzi,
is not
mobilizaci a laterálně.
Right. So we did extension mobilization, increase no worse, and no effect on neuro and range of motion.
Tak vidíte, že extenze mobilizace zvyšuje a není zhoršení a zase bez jakéhokoliv dopadu na neurologické symptomy a rozsah.
What's your diagnosis?
Jaká je diagnóza?
It still could be a derangement, isn't it?
Mohl by to být derangement.
Right. I want you to think on the first day I just did extension lying better. Next day I did more. I did for sure more because I did more reps. It's already a progression, came back not better. Then we put some pressure on it. So we get an increase, or we got a decrease, but no better. Yeah? We are now at an increase no worse by extension mobilization.
Představte si, jak to šlo postupně. To znamená, dělali jsme extenze v lehu,
I still would
zlepšení,
like to go
pak
to lateral.
víc cviků, ale bez zlepšení. Teď už máme dokonce není zhoršení, ale zase bez efektu na rozsah pohybu a tak
For me,
dále.
this sounds like I'm going to buy chocolates. For 10 euros, I have a nice pile of chocolates, right? I go back the next day to the same shop because I thought, wow, that's beautiful chocolates. And now I pay 10 euros and I get less. And the next day I get less again. I don't want that.
To mi připadá, jako bych chodil do obchodu a koupil si tam za 10 € první den super tabulku čokolády, s nimi říkám, je výborná, zajdu si pro další, přijdu tam druhý den, ale tam už mi prodají míň. Pak tam přijdu třetí den a zase za ty samé peníze dostanu míň. A to se mi nezdá správně.
So now we did extension in lying with hips off center, and now she feels worse.
Tak, teď jsme si udělali extenzi v leže s pánví mimo středovou pozici a máme zhoršení.
And no effect on neuro range of motion.
A opět bez dopadu na rozsah pohybu a na neurologickou symptomatiku.
How would you call this patient? Classifying.
Jak byste klasifikovali pacientku teď? Still derangement, somebody says.
Still derangement. Well, you want to do flexion rotation, do you?
Chcete zkusit flexe rotace?
Well, there's nothing wrong with it. You can do that.
Na tom není nic špatného, můžeme, co by ne.
But then you have to stop, okay?
Ale pak už je potřeba přestat. To je ta chvíle.
So this is the pattern I see a lot. And if I see that, I stop a little bit more early, I have to say. So it's called the DMGL pattern. It's brand new. Nobody knows except you and the other group.
Tohle je vzorec, který v klinické praxi vídám docela často a ten nám právě říká, kdy vlastně přestat s tím testováním. Já bych třeba skončil už trošku dřív, ještě před těmi flexemi, rotacemi a já tomu pracovně říkám DMGL. Je to Brusunový koncept, nikdo to nezná, jenom vy a ta druhá skupina, co to byla před.
Do more, get less.
Říkám tomu do more, get less, to znamená děláme víc, ale dostáváme méně.
It's a real bad pattern. And if I look back in around 15,000 radicular syndromes I've seen in my life, if I see this, I start to switch off a little bit more before flexion rotation, to be honest.
A to není nic moc, to samozřejmě nechceme. A když se podívám na ty stovky radikulárních syndromů, co jsem za svou kariéru viděl, tak můžu říct, že můžeme skončit s tím testováním ještě trošku dřív a už se třeba k těm flexním rotacím ani nepropracovat.
As you don't change range of motion or neurology.
Pokud se nám stále nemění rozsah pohybu a neurologická symptomatika.
I'm more happy to make it worse. So my straight leg raise, it's get a little bit worse. Then at least something is happening. I'm more happy with that than it stays the same, it stays the same, it stays the same, it stays the same.
Já jsem v podstatě radši, když vidím, že se to horší, protože je tam nějaká změna. Je to pořád lepší, když se pořád neděje nic. To je tenhle případ.
And of course you don't want to make it worse and worse and worse and worse.
Ale samozřejmě to nechceme zhoršovat kontinuálně, to není ten smysl. Ano.
Okay, do you got this? Right?
Rozumíte tomu, co říkám? Co vám chci říct?
So we did flexion rotation, still not happening. Then you really have to decide, how do you call it now?
Takže když uděláme flex rotace a pořád nic, pořád bez změn v ROM a v neuro, tak jak tomu říkáme?
Radicular syndrome without directional preference.
Bez směrové preference, ano.
Got that?
V pořádku, rozumíme?
So I hope you keep an eye on the mechanical changes, which are really important. And if you add more and you get less, that's no good.
Takže je potřeba sledovat ty mechanické změny, ty jsou tady klíčové a ve chvíli, kdy tady my pořád děláme víc a přidáváme, ale získáváme míň a míň, tak to není dobrá cesta, je to tenhle ten případ.
So now we're going to have a look at radicular syndrome, hot versus cold glutes. You have a question?
Jak by vypadala vaše první návštěva, když teda ne takhle, tak jako jestli by se to dalo zvládnout za první návštěvu, anebo dojít až k té třetí a potom říct, tak tedy ne.
But would you be able to do this all in one visit, or do you really need 3 visits to go through this all to reach this conclusion?
Through all the forced regressions, you mean?
Aha, myslíte ty progrese.
No. As long as like the first day I found better, I think it's not changing on range of motion and neurology. That's my sort of I don't like it. I'm not going to be that happy to the patient, saying, "Well, we can cope with this, right?" So we'll be backing off a bit in a good prognosis because it's central or it's directional preference.
Během té první návštěvy je důležitý ten výsledek, takže když já uvidím zlepšení, ale uvidím, že je to beze změn v tom rozsahu pohybu a v neuro, tak nebudu tak spokojený. Budu vědět, že tam je tahle ta složka, která není úplně ideální a bude to taky ovlivňovat to, jak budu komunikovat s tím pacientem. Jo? Nebudu tak nadšený ohledně té prognózy, nebudu říkat, jo, toho se zbavíme za pár sezení, budu na to prostě trošku opatrněji.
Because often you're going to see, well, today there is no range of motion change, there is no neurology change, but the next visit, wow, my straight leg raise is way further and the patient is moving better and the pain is still better. So then it goes on, right?
Protože velmi často se stane, že třeba během té první návštěvy tam to zlepšení třeba v rozsahu pohybu není, ale na té druhé návštěvě už jo a najednou se to všechno začne ubírat správným směrem. Takže to je vlastně jenom takový vykřičník během té první práce s tím pacientem.
And what we're going to do now is looking at inflammation of the nerve roots. That's connected to that as well. If it's really heavily inflamed, you just can't do a lot of testing. So you need to back off more early with all the testing.
Teď se podíváme na ten zánětlivý faktor, protože zánět toho nervového kořene s tímhle vším hodně úzce souvisí a ve chvíli, kdy je ten zánět přítomný a je hodně aktivní, tak vlastně moc toho testování dělat nemůžeme, nevyplatí se to.
So looking at radicular syndrome, and this is about all radicular syndromes. It's not divided yet into derangement or radicular syndrome without directional preference. And we look at the natural history. How does a patient get better on his own without intervention?
Teď se tady budeme bavit o radikulárním syndromu jako o sběrné kategorii, to znamená bez toho rozlišení na derangement a bez směrové preference. A budeme se trošku zajímat o problematiku spontánního uzdravení. To znamená, jak často se nám ten pacient vlastně zdraví sám od sebe.
And this is related to herniated disc because that's mostly the reason for having this radicular syndrome.
A to je samozřejmě úzce spojeno s výhřezem destičky, výhřezem meziobratlové plotenky, protože to je velmi častá příčina toho radikulárního syndromu.
So if you look into natural history studies, then it starts mostly, some people start with back pain, but at least at a certain moment you have your maximum leg pain, right? And that leg pain stays on for a while. And often it's between 6 and 10 weeks that you get a drop-off of that leg pain.
Když se podíváme na některé studie této problematiky, tak uvidíme, že samozřejmě pacienti mohou pociťovat různou bolest, buď v zádech nebo v noze, a ta bolest v té noze v jednom bodě vlastně dosáhne svého maxima. A v tomto maximu po nějakou dobu vydrží. Většinou to bývá tak 6 až 10 týdnů.
And this 6 to 10 weeks is necessary for the body to get rid of extrusion or sequestrated material. It eats it up by itself, right?
A těch 6-10 týdnů je vlastně nezbytných pro to, aby to tělo zvládlo zpracovat ten materiál, který tam vyhřezne. Takže to je vlastně ta doba, než se to tělo popasuje s tím problémem, který tam nastal.
So and then often the pain starts to fade out, and that's happening in 80% of the people. 80% of the people.
Co se velmi často po těch 6 až 10 týdnech stane, je, že ta bolest začne sama o sobě polevovat. A jak vidíte, stává se to ve valné většině těch případů, je to až 80% pacientů s tímto problémem.
So of course that's not a linear line. They will have a day that is getting a bit worse again, but all over in a few weeks it starts to die out.
A jak vidíte, tak ten proces samozřejmě není lineární, někdy ten pacient se bude cítit hůř, někdy líp, bude to trošku fluktuovat, ale celkově vzato v dlouhodobém měřítku ten proces bude probíhat takto.
So 80%, you have 20% left, which keeps that pain on a maximum level in the leg.
Takže u 80% dojde k tomu spontánnímu odeznívání té bolesti po 6 až 10 týdnech, ale vidíte tam i tu červenou linii a to jsou ti, u kterých ta bolest vlastně přetrvává v té maximální intenzitě.
And this is soft evidence, it's not a lot, but we knew a sort of, if you have 16 weeks maximum leg pain, then the chance that you get better on your own is not 80% anymore, it's only 10%.
A tady pro tu skupinu bohužel zatím nemáme tolik vědeckých důkazů a tolik studií, které by dokládaly, jak tam probíhá ten další proces toho uzdravování. Ovšem některé studie naznačují, že pokud ta bolest přetrvává v té maximální možné míře, možné intenzitě 16 týdnů a déle, tak ta pravděpodobnost, že tam dojde ke spontánnímu uzdravení toho pacienta, je už jenom 10%.
So this means if I have 100 patients with a radicular syndrome, 80 get better on their own, 20 won't get better on their own, and from that 20, only 2 get better on their own later on.
Takže to tedy znamená, že pokud bych měl soubor 100 pacientů s radikulárním syndromem, tak 80% nebo 80 z nich se mi vlastně zlepší samo od sebe, a pak mám těch 20%, kde ta bolest přetrvá déle, a z těch 20 ještě další 2 vlastně dojdou toho spontánního uzdravení, ale o něco později.
So if you have a radicular syndrome in your clinic, you're doing well with them because 80% get better anyway. It doesn't matter what you do.
Takže pokud pracujete s pacienty s radikulárním syndromem na svých pracovištích, tak je to vynikající, protože 80% z nich se vám prostě zlepší, jak budete dělat cokoliv.
All right. So I have a lot of if I do speeches in physical therapy, but not MDT areas, I ask this question. So what do you do with a radicular syndrome? So what do most physical therapists do if they have CO radicular syndrome? What is the typical treatment? Not MDT treatment.
Já když přednáším fyzioterapeutům, kteří nedělají metodu McKenzie, nedělají MDT, tak když jim přednáším radikulární syndrom, tak se jich ptám, co s tím dělají. Co myslíte, že mi většinou odpovídají? Jak ty pacienty řeší? Prosím?
Yeah, some neurodynamics, where evidence lacks like hell in radicular syndrome, but that's something else.
Takže nějaká neurodynamika, tam nejsou úplně vědecké podklady, ale budíš.
On radicular syndrome,
Co se týče radikulárního syndromu konkrétně.
And the rest?
What else? Somebody said the core.
Core stability, right? There's a
Stabilita
pile of
středního
evidence
těla.
that core stability doesn't work on a radicular syndrome based on a herniated disc, but that's on the other side.
Často se to řeší posílením
Can you put
středu
on the
těla,
light?
stabilita těch
Can you
svalů,
put on the
vlastně,
light?
které drží tu posturu,
Can you put on
ale
the
je
light
potřeba
of your
říci, že
telephone?
u toho radikulárního syndromu,
On.
půjčit telefon se světýlkem, jestli by šlo, ale u toho radikulárního syndromu, který je založen na výřezu té plotenky, vlastně není žádná vědecká báze, která by říkala, že tohle tam pomůže.
So my treatment is white light treatment.
Já to léčím takzvanou metodou bílého světla.
I say to patients, look in white light every morning at the same time for 5 minutes.
Řeknu pacientovi, každé ráno si zapnete na telefonu baterku,
You do that for
ve
3
stejnou
months.
hodinu, 5 minut budete zírat do toho světla a budete to dělat 3 měsíce ve stejnou dobu.
Pay me 2,000 euros.
Bude to stát 2000 euro.
And if after 3 months it's not helping, you get your money back.
A jestli vám to za 3 měsíce nepomůže, tak dostanete peníze zpátky.
Do you know how much I earn?
Kolik vydělám? Slovní úloha?
80%.
80%, že?
That's the same as I ask people, so you do core stability. How long does it take you to get a good result? And mostly they say, well, that's 3 months because that's training of muscles, which is pretty logical, isn't it? So, and then I ask, how long or how much result do you have? Around 80-85%. So then I say my white light therapy, which is helping as good as well.
A to je vlastně přesně stejný závěr, ke kterému docházíme i s těmi fyzioterapeuty, kteří nedělají MDT. Já se jich ptám, co dělají, oni říkají, no tak posilujeme ten střed těla. Já říkám, aha, jak dlouho to tak trvá? Oni říkají 3 měsíce, jsou to svaly, tak to je logické, že jo, než to zabere. Já říkám, aha, a kolik máte úspěšnost? Oni říkají, tak 80%. Tak já říkám, no tak to je úplně stejné jako s tím bílým světlem vlastně, že?
Right. So radicular syndrome, good natural history. If you want to interfere with MDT, and we have done that, many studies have looked at how much of the radicular syndrome patients can be centralized, can be a derangement, then it's in between 30 to 70% in different studies. And we have around 10 different studies on this, right?
Tak, vidíme tedy, že u toho radikulárního syndromu je dost vysoká míra toho spontánního uzdravení. To neznamená, že nemůžeme intervenovat pomocí metod MDT, právě naopak. Máme dokonce i nějaké studie, které dokládají, že v těch 30 až 70% to může přispět.
So the 30% is my clinic, so I'm really bad in centralizing patients. But I'm in secondary care and patients have had a lot of other therapies. But I think in a private practice, physical therapy, you could, I think 60% should be possible in a radicular syndrome to centralize.
Z mojí zkušenosti a na našem pracovišti je to spíše kolem těch 30%, ale já jsem v rámci sektoru sekundární péče, takže tam je to tak, že ti pacienti už ke mně přicházejí vlastně přes někoho, ne napřímo, ale myslím si, že na specializovaném fyzioterapeutickém pracovišti se to klidně může u toho derangementu blížit těch 70%.
So now we're going to look at how do you recognize in your history taking and in some tests if you have to deal with inflammation.
Pojďme se teď podívat na to, jak během anamnézy a vyšetření pacienta zjistíme, jestli je přítomen záměr nebo ne.
And there are almost no clinical studies done which can predict that. But this is one of them which I really like because this is a physical therapist, John Ford, from the Melbourne University. He published this in 2020 in BMC.
Tady opět těch vědeckých studií bohužel nemáme tolik, nicméně existuje jedna, kterou já mám ve velké oblibě, protože ji provedl fyzioterapeut pan Ford na univerzitě Melbourne a je to studie z roku 2020.
So we was doing examination on patients, taking a lot of questions and tests, etc. And then they would take out a little bit of the disc material very close to the nerve root. So they really looked at inflammation markers in that piece of material in the laboratory to see if there are inflammation markers and how many are there.
Ta studie byla vlastně provedena tak, že oni prováděli velice podrobná vyšetření vybrané skupiny pacientů, nabrali anamnézu, udělali různé testy a podobně a potom odebrali trošičku hmoty vlastně z té meziovratlové proténky velmi blízko toho nervového kořene a na ty se pak podívali v laboratoři, aby zjistili, jestli v té hmotě jsou přítomny nějaké zánětlivé markery.
So and then he was looking at what do those patients say. So he looked back in his files. And with the patients with high levels of inflammation markers, what have they told me? How did I test them, right? And he created a prediction model for inflammation based on those tests.
No a když u některých těch pacientů odhalil, že jsou tam vlastně ty markery přítomné ve velké míře, tak se vrátil k tomu testování, které proběhlo předtím, podíval se na výsledky těch vyšetření, které s nimi provedl a díval se vlastně, co sami ti pacienti udávali, jaké byly výsledky těch různých testů a podobně. A na základě toho vlastně udělal takovýto predikční model, podle kterého lze určit, jestli je tam pravděpodobnost zánětu či nikoli.
So the people who had really high levels of inflammation, they were saying, I have back pain below 5. It's not talking about leg pain, but back pain below 5.
Tak, co udávali ti, u kterých byly tedy ty markery přítomné ve velké míře? Za prvé udávali, že mají bolest zad méně než 5 z 10. Vidíte, že bolest nohy se tam neuvádí, ale tím prvním indikátorem je tedy bolest zad.
And they would have the day after injury more leg pain.
Dalším indikátorem je, že se jim příznaky den po tom úrazu nebo po tom incidentu zhoršily.
And that's the only question where I think, oh, that's a difficult one, because my patients, if they have 15 months of radicular syndrome, they don't know anymore. So I ask a different question there. So if you load your spine, if you do a little bit of sports or you do a little bit too much, how long does it take before it eases off? And if it's more than a few hours, then I would say, well, they have that's an inflammation pattern as well.
No to je jediná z těch otázek, se kterou já mám obecně trošku problém, protože mám spoustu pacientů, kteří jsou chroničtí, kteří už třeba ten radikulární syndrom mají 15 měsíců a ti si samozřejmě tak dobře nevybavují, jestli se jim to den po tom úrazu zhoršilo nebo zlepšilo a podobně. Takže my si tu otázku malinko přeformulujeme a ptáme se těch pacientů, jak to vlastně vypadá po zátěži. Ve chvíli, kdy si ten pacient jde zasportovat, jak dlouho mu vlastně trvá, než se mu zase uleví. A to je pro nás ekvivalent téhleté druhé
otázky. And those really inflamed patients have a major loss of flexion. So we have that all in our assessment form. It's already there. If you find major loss, then it's less than 30 degrees of flexion.
A pak tam máme ten rozsah pohybu v bederní páteři a to vlastně už máme i v těch evaluačních dotaznicích, takže to si můžeme velmi rychle dohledat.
And also the other ones are in our assessment form, which is great because you don't need to write anything new. So then he said, I have 4 questions and you need 3 to be answered positive to have a minimal, what he calls a minimal clinical inflammation score.
Tak, toto jsou tedy indikátory a kromě nich jsou vlastně ještě definovány 4 otázky. Vy vidíte jenom 3, ale je tam ještě ta 4, o té vám řekneme, kde je potřeba, aby byla pozitivně zodpovězená většina z nich, to znamená 3 ze 4.
Question 4 is fallen off, but I will tell you. So the first one is, do you have constant pain? The second one is, if you walk a short distance, does it release some leg pain? The third one is morning stiffness, morning pain more than 60 minutes. And the last one is, do you have significant night pain? And I'll come back on that.
Tak vidíte, že první ta otázka zda jsou ty bolestivé symptomy konstantní, druhá je, jestli se vyskytuje ranní stuhlost, která trvá více než 60 minut, za třetí krátká procházka, která nezmírňuje příznaky a za čtvrté jsou to závažné symptomy v noci a k tomu se ještě vyjádřím.
So significant night pain would be positive if the patient would say, I need to go out of bed to walk around, or I need to take a painkiller before I can sleep further. So it's not the patient who just turns, wakes up and sleep further. It's really, I need to do something.
Závažné symptomy v noci nebo závažná bolest v noci pro nás znamená, že se ten pacient skutečně musí zvednout z postele a trošku se projít, případně si vzít nějaký lék na úlevu od bolesti. Není to takový ten pacient, co se třeba probudí, chvilku se vrtoší a pak zase usne. To není ono, je to skutečně něco, co ho zvedne z postele, tak říkajíc.
So again here, sorry, the 19.9% should be behind sensitivity. So it has a really high sensitivity, a high specificity of 92.9, so 93%, and a prognostic prediction of 93% as well. So if you have those signs, all, you know you're dealing with high levels of inflammation.
Tady se nám trošku rozházela ta čísla, nicméně 90,9 je číslo pro senzitivitu, 92,9 je potom specificita a přesnost predikce je potom asi 93%. Takže vidíte, že všechny ty faktory toho testování jsou poměrně vysoké a znamená to tedy, že pokud máte pacienta, kde jsou přítomny všechny ty indikátory a minimálně 3 ze 4 z těch otázek toho skóre klinického zánětu, tak máte téměř jistotu, že je tam ten zánět ve velké míře přítomen.
So now your next task. You got a new assessment form of Miss P, and you have to find out if Miss P is highly sensitive or not, or highly reactive or not. And if she's highly reactive, we still have to figure out, is that a derangement or is it a radicular syndrome without directional preference?
Tak, teď máte před sebou další kazuistiku a mě by teď zajímalo, jestli paní P je podle vás vysoce senzitivní pacientka nebo vysoce reaktibilní pacientka a jaká tam zase bude ta klasifikace z hlediska derangementu.
So now you have to think about how am I going to test this patient with this high or low inflammation.
Tak, teď je potřeba se zase zamyslet nad tím, jak si pacientku vyšetříme a jedna z věcí, která to bude udávat, bude i ta přítomnost nebo naopak nepřítomnost zánětu.
And you may discuss that with your neighbor, otherwise it looks
a klidně
like
to
a
můžete
test.
probrat i se sousedem, pokud chcete diskutovat.
So first question is it high or low reactive? Second question is, how do I test it?
Tak, otázky ještě jednou na slajdu, takže vysoká nebo nízká reaktibilita a pokud je tam derangement, jak budeme postupovat.
Well, we did a case on derangement of radicular syndrome without directional preference. So I have a new pattern. We call it DMGL pattern. Yeah, so if you find a DMGL pattern, just do more, get less. so yeah, the first one is extension line, they get better, and then comes back, didn't change, not in the mechanical area. And then, so we give overpressure, and now it's getting no better. And then you give mobilization, and now it's getting no worse. So you do more, and you get less. So it's funny. Yeah, and then and no changes in mechanical. So it's about they keep on testing. Yeah, we can do cycliding. Yeah, we can do that. So how many times do you want to hear? How long do you think your patient is gonna say, "Oh, yeah, we're gonna do that for a month?" So I have this beautiful picture of Defang. DMGL. Right, is this high or low reactive?
Tak, co ta reaktibilita? Vysoká, nízká? Jak to vidíte?
Yeah,
High.
very difficult to find.
Výborně, ano.
No, it's highly reactive.
Vysoce reaktibilní tedy.
Okay, so how do you start your testing?
Jakým způsobem začnete s testy? Jak budete vyšetřovat?
Can you please explain the signs for the irritability?
Right.
What's the reasoning?
The reasoning for irritability is,
Oh, it's Czech, right? Let me see. What you looking for?
constant symptoms
Konstantní symptomy.
in the leg, morning stiffness, I think.
Ranní stuhlost by tam někde měla být.
Yeah, getting worse, but it's not related to that inflammation score.
Zhoršení,
Right?
ano, ale to nesouvisí s tím skóre toho zánětu, jak jsme si ukazovali před chvilkou na tom nástroji.
So it's constant, and I think it says AM, and it should say something like more than an hour.
Tady by mělo být někde
Does it say
ráno,
that?
trvá to víc než hodinu, než ta vzduchnost přejde, že jo, něco takového.
Right? Short walking
Krátká procházka.
is not helping. It
Nepomáhá,
should be somewhere.
to je další z těch znaků,
Right?
co jsme tam měli. že jo?
And then disturbed sleep, yes.
Ano, přesně, nějaké problémy se spánkem. Něco
And I don't
takového.
know if there should be something like, what does that mean, disturbed sleeping? Is it only when you turn and you sleep further, or is it I need to go out of bed?
A tady bychom měli mít
Is
ještě
there anything
objasněno,
here? Because I
jak
can't
to s
think.
tím spánkem je, jestli se ta pacientka budí a musí vylézt z postele, anebo... I couldn't see where it is. Yeah, it's hard for her to find a comfortable position.
Yeah, so it's hard to find, but that's not totally.
To je takové nejasné, že? To nám neříká, jestli skutečně musí vstát a třeba se projít, nebo jestli se tam jenom vrtí.
And
Takže to
then
je s otazníkem.
flexion, major loss, right? Back pain below 5,
Bolest zad pod 5.
right? And then the difficult one is, did your leg pain start a day later?
A pak ta záludná otázka, jak to bylo ten
So
den
I just
po tom
follow that
incidentu.
schema.
Takže v podstatě člověk může jet podle toho schématu, tak jak jsme to viděli na tom předchozím slajdu, a jenom si dohledávat ty informace v tom
But
dotazníku.
I'm asking a lot about, so you do something, what do you like? Oh, in the Netherlands, everybody likes biking. So I want to bike. How does it feel if you come back? Oh, it can be painful. So how long does it take you before your pain settles down? Oh, it can be half a day or even till the next day, or I have a really bad night after that. So that's sounding very inflammatory as well, right?
A samozřejmě z té pacientky doptám trošku lidsky, zaměřím se na něco, co ráda dělá. Třeba u nás v Nizozemsku všichni jezdí na kole, tak se zeptám, jak je to, když se jdete někam projet na kole. Ona říká, no tak trošku to bolí, já říkám, jak moc. Ona říká, druhý den, třeba půl dne to nemůže přejít, nebo celý druhý den je špatný, nebo pak mám těžkou noc a podobně. A to už bych si tam klidně mohl zařadit.
Okay. Ava, how much time do we have?
Evo, jak jsme na tom s časem, prosím? 1 minute.
You're not joking today.
No,
All right.
she means it.
Right. 1 minute. What do we need to test in her
Co je
case?
potřeba vyšetřit?
How would you start testing?
Jak byste začali s testem? Jakým
Would you
způsobem?
start, let's split it up a bit. Would you start with the repeated movements or sustained positioning?
Opakované pohyby? Sustained position.
Why sustained positioning?
On her belly, somebody said.
Yeah, on our belly, maybe we come back on that, but why
K tomu
sustained?
se vrátíme. A proč tedy tato varianta?
Because it's very acute, high levels of pain,
Akutní,
high
velmi
levels of
responsivní,
inflammation.
velká bolest, velký zánět.
Patient is saying, I'm better when still. Is that true?
Říká pacientka v klidu lepší?
I'm better when still is also meaning, well, I don't like to move too much.
To nám taky říká, nechci se sebou nic moc dělat, když se hýbu, bolí to.
And yes, you could start on the stomach.
A určitě bychom mohli začít na břiše, ano?
There is moderate loss of extension in this case, so maybe that's possible, but sometimes if that's too much and it starts to radiate already, what would you do?
Samozřejmě tam je to lepší s extenzí, ale když je to horší a začne nám ta bolest vystřelovat, tak co je potřeba udělat? Aha,
Put something underneath the stomach, or you could think as well, put them on our back and bring the knees up a bit. And just sustain that. You do the same thing. You give a little bit of space to it.
Abychom vytvořili trošku prostoru.
And I like that one because then I can roll over to flexion rotation.
To je za mě dobrá metoda,
Easily.
protože pak se můžu snadno přesunout k flexím rotacím.
Right? And if I think about those very acute, very inflamed radicular syndromes, most likely, not always, you just have to test out, but most likely it's going to be flexion rotation away from the pain. So your painful leg is up, not down, which we normally do. We want to reduce the derangement, but now you want to open up the foramen. You want to give space to this swollen nerve root. You don't want to make it more angry, right?
This is neurodynamics.
This is McKenzie, because the neurodynamics. I will tell you later.
They do it also.
I know.
Takže pokud je to akutní radikulární syndrom s vysokým zánětem, tak
But would you do
většině
that?
případů bude lépe pracovat s tou bolestivou nohou
Yeah,
nahoře.
you would
Protože v
sustain.
tomhletom chvíli chceme
Sorry.
otevřít ten foramen a udělat prostor kolem toho oteklého zaníceného kořene.
Right.
Yes.
So, and then sometimes it's important, even if you put that patient on the side, or you turn the legs to the side, I have to say, then to take cushions in between the knees as well, to not go into a deduction, because that will tense up the nervous system as well. So then you just take
A pak je
pressure
samozřejmě důležité pamatovat na to, že pokud budeme pacientku převracet na bok, nebo lépe řečeno jenom nohy převracet na bok, tak je dobré dát polštář mezi kolena.
And that's the patient for sure, where you never get an answer on day one. Is this gonna be to centralize or not? Right? So you need to test that out for a few days.
A samozřejmě první den se určitě nedozvíme, jestli tam je centralizace nebo ne, to se bude potřeba vyšetřit vlastně v průběhu času.
Well, 1 minute is gone.
Tak, minuta za námi.
Is there any one burning question?
Máme jednu palčivou otázku, která nám nedá spát.
Is it burning? Because
Je
we
to
talk
palčivá
about
otázka,
inflammation.
protože přetahujeme.
Kolik se jako terapeuti šťastnější, když tam nemá střížený kolasy?
How much happier am I as a therapist if there is no crossed syndrome present?
Cross straight leg raise, you mean? How happy you are?
Jak šťastný jste vy? Co byste řekl? I'm not, he says.
Nebo takhle, oba vás mají střížený vlasy. Tak kolik by mohla být lepší prognóza, kdyby na té střížený vlasy neměl?
So how better could the prognosis be for these two patients?
I don't care.
Je mi to fuk.
If you have a cross straight leg raise positive and you're straight leg raise positive, the only thing you know, it's gonna be a herniated disc.
To nám ukazuje jenom na výhře z té ploténky.
The chance is really high.
Nebo ta pravděpodobnost je velmi vysoká.
If I cough and it shoots in my leg, it's even higher.
A když zakašlu a vystřelí mi ta bolest do nohy, tak je to ještě pravděpodobnější.
I have a 96%, if that's happening, if you cough and you get this shooting pain down the leg, you have a 96% chance that you're gonna find on the MRI a herniated disc. Did you know that?
Pokud při zakašlání pacient pociťuje vystřelující bolest do nohy, tak je asi 96% pravděpodobnost, že se na rezonanci ukáže vyhřezlá destička.
But that's what you're gonna see on the MRI.
Protože přesně to pak uvidíme.
And then we start from the beginning.
A pak začínáme v podstatě od začátku.
Do your repeated movement, see what happens.
Opakované pohyby, sledujeme, co se děje a tak dále.
Is that an answer?
Odpověděl vám to na ten dotaz? I also have a burning question, I believe.
But that's the second, and Eva is looking very angry
Eva
at
se
me.
strašně mračí. Okay, I will ask you in the break. When we take coffee.
So these are all the slides I had, and they are really interesting, but I can't show you.
Toto jsou vysoce zajímavé slajdy, které jsem pro vás měl, ale vy je neuvidíte.
So you have to come to the masterclass,
Takže
which
musíte
is
všichni
happening
přijít na
in
masterclass.
September, okay?
A ta se bude konat v
See
září,
you all.
takže jste všichni srdečně zváni.
I want to have an applause for her because I'm very impressed by her translation.
For the ones who come in, just please come down because you need a yellow or a green card in front of you.
Prosím vás, pojďte sem dolů, protože tady dole jsou zelený a žlutý kartičky. Nebuďte nahoře, pojďte sem dolů.
So just move down because down here we have yellow and green cards. You need either a yellow or a green card in front of you.
Tady dole jsou zelený a žlutý kartičky a všichni potřebujete mít zelený a žlutý kartičky, takže neseďte tam, kde nejsou.
Works. I don't know. Yes.
Je tady strašně moc míst volných se zelenýma a žlutýma kartičkama.
I was thinking then half of them are gone home. I was thinking then half of them
Vepředu
are
i v
gone
druhé
home.
řadě volný zelený a žlutý kartičky. Máte sedět tam, kde jsou ty zelený a žlutý kartičky. Je jedno? Jedno. V první řadě vidím 1, 2, 3, 4 volné kartičky. Nikdo tam nesedí.
How come you've got more green than red than yellow? I said, how come you've got more green than yellow?
Some leftovers.
Yeah.
There.
No, sedněte si tam, na kraj taky. Na kraj, tam jak je žlutá kartička. Yes.
Okay, good.
A
Nice.
takže teď bych chtěla prosím uvést poslední přednášku, kterou vám přednese Georgem Suppem, jeden ze slavných McKenzie terapeutů z Německa a taky je součástí i světové organizace v boardu, který vždycky rozhoduje o tom, co se bude kde vlastně prezentovat. A potom Joe Chambers, zase to neřekla asi úplně dobře, z Anglie, která je předsedkyní McKenzie institutu v Anglii. Takže užijte si tuhle poslední přednášku a pak určitě neutíkejte, protože víte, co jsem slíbila, jo? Nějaké odměny a bude Kahoot.
Okay, good. So, good afternoon, everybody. Good afternoon, everybody. It's my great pleasure, it's our great pleasure to be here. And before we start our presentation, here's a... It's not on? Is it on? Okay, yeah, it's on. Before we start our presentation, actually, congratulations to you, to the Czech Physiotherapy Association or the Czech Physiotherapy Union for 35 years. So in 1991, this association or this union was founded, and it's this year is your 35th birthday. Congratulations for that. And warm wishes from World Physiotherapy. So it's our pleasure to be here and to be the latest part, the last part of this day. And I hand over to my dear colleague, Joe.
Thank you. It is lovely to be here, and actually at the end of the day to see so many of you still here, that you've not kind of headed off, because it's obviously been a good long day for you. So just to introduce myself, as Ava said, my name's Joe Chambers, and I flew over from the UK this morning. So I'm English, but I live and work in Scotland, so much better further north you go. So I work in the NHS in a big, massive teaching hospital, and I work in a neurosurgical service. So we've got 16 neurosurgeons, so my role is to assess patients to determine whether they need surgery or not. So my default position is spinal patients, because that's what I see all day, every day. So any patient example that I may use, I apologise, because it's all spinal stuff. But I wanted to put up a couple of nice pictures, because Scotland's beautiful. So if you've never been, you should go. We've got the mountains, we've got the whiskey, we've got the haggis, but maybe you didn't know we've got a beautiful coastline as well. White sandy beaches, turquoise seas. It's absolutely freezing and there's nobody there and there's loads of midges, but it is beautiful. And another thing for Scotland, actually, we got into the World Cup. It's like, how did that happen? But it was amazing walking through the airport this morning, and all the guys were in their kilts and everything. It was a really good buzz. And the Scottish government has given us all a day off, so I don't even work on Monday as well. It's like double bonus. So it's all good. So back to what we should be talking about. So we know that the biopsychosocial healthcare model and how MDT fits into that. It's very holistic, it's very evidence-based. And one of the factors of the approach is that we do a thorough assessment, don't we? That the assessment of the patient, taking their history, their examination, repeated movements, testing, loading, to make their classification based on their symptomatic and mechanical response. But it has a very strong psychosocial emphasis. It supports self-management, self-efficacy, that the patient is confident that they can treat themselves. There is that feedback loop that reassessment so that we're comparing the symptom changes to our baselines. And that helps us to confirm our diagnosis, but look at progression of treatment, whether we need to look at false alternatives or false progressions. And that's our traffic light system. And also there's a strong framework for education. So a patient doesn't need to know just what exercises to do, but how to do it. What is the expected response from their exercise program, but also what do they need to do if things change for the worst? And sometimes that might happen. However, in a busy clinic, we can also succumb to the pitfalls of when we're rushing around and we're maybe a little bit behind schedule, that we maybe not put the focus on our communication. We may become a little bit more biased, a little bit more leading with our questioning, which then may kind of sway where we're going in terms of treatment and not be patient-centered communication. And also, we can jump to those assumptions, particularly in the classification of derangement, and the presumption being that if we can get the patient's symptoms to centralize, then obviously they're going to comply with treatment. And then we maybe don't think about and acknowledge the importance of patient education. And what we do know is that our interaction with the patient may outweigh our intervention. So if a patient doesn't feel heard, if they don't feel that they've been listened to, if we've not asked them about the context of their symptoms, what effect it has, what impact this is having on their daily life, we may prescribe the best exercise to them, but they're not necessarily going to engage. And that means that they're not necessarily going to get the positive outcomes that we would expect. So how do we make sure that our interactions with our patients are positive? That is about developing the therapeutic alliance, that we're together with the patient. There's 3 key factors to this, and it's about working together with the patient. So collaborative goal setting. This is where we openly discuss and agree and work towards specific goals that are meaningful for that individual patient. These goals have to be what the patient wants to achieve. So that might be something like returning to work, straightforward. That might be playing with their grandkids, okay? But it might be doing an 18 holes of golf. Everybody in Scotland plays golf. I talk about golf all the time, even though it's the most boring sport on earth. But golf might be that patient's goal. So it's individualized to them. Another key factor is shared decision-making. So we can involve the patient in how their treatment progresses. So we're not dictating to them, but they're involved. And a really good example of this is, say you've got a patient with back pain and leg pain. Spinal, sorry, that's where I go to. Back pain and leg pain, and you're testing flexion, you're testing extension, and both of them make their symptoms worse. What we know is that we've highlighted a lateral component to this. So we need to go into the frontal plane, and we've got options, we've got choices. And it's always good to have choices. We could go side glides and standing, or we could go hips off center. And that's a perfect opportunity to get the patient involved, to ask them, if we test this, if we do this, is there one that you feel gives you a better response that's more appropriate for you to be dealing with your symptoms at the moment? So we're working together on how to progress and determine which is the best exercise for them. And the third key factor with the therapeutic alliance is trust, that therapeutic relationship. It's about taking the patient at face value, listening to their information and not being judgmental. And that might be something that is blatantly obvious, but what we know is that it is a really strong predictor of having a positive clinical outcome if we have a good therapeutic relationship with the patient. So what does that mean to us as clinicians? Is that we're giving up control. We're not dictating. We're not the expert prescribing, you will do this because I've said for you to do this. We're working towards a more collaborative a more guiding, a more facilitating relationship with the patient, rather than standing up and they're down here. We're on an equal basis. We're coming together to solve the problem. So we're working together with that shared goal. We're working together to get what we both want out of the session, out of that treatment. We're working together on being on the same page with the patient. So we're working together on all aspects of treatment. And that therapeutic relationship is something that we don't necessarily think about. We either get on with people or we don't get on with people. But there is lots of aspects to it. There's lots of building blocks that come together to create a really strong bond, even in a clinical situation. So let's look at these. That emotional bond is a connection between two people as individuals. It's built on trust and confidence. And that trust and that confidence can be in our abilities. Do they trust that we have the skills and the knowledge? Do they trust us with the information that they want to impart on it? Are they confident that we can do a good job for them? It's built on mutual respect, that we're coming as equals. There's not a power dynamic. And for respect to be there, we have to give it before we get it. That therapeutic relationship involves empathy, walking in somebody else's shoes, having an understanding how somebody else might be feeling, and looking at things from somebody else's perspective. Something might be very straightforward to us, but might seem very complex to the patient. So we have to look at it from their perspective to be able to give the appropriate support and education. But also it's about being friendly. It's about being open. And it's about encouraging an atmosphere of openness for people to be able to discuss their thoughts and feelings. I know I would rather talk to somebody that looks me in the eye and gives me a bit of a smile rather than somebody that's avoiding my eye contact and looks gruff and grouchy. I don't know whether they're English, Scottish words or whether they work with translation, but that kind of face rather than that kind of face, if you know what I mean. But there's also, it's involving genuineness and integrity. It's about being authentic. It's about being real. It's about what we're thinking on the inside and how we're acting on the outside is the same. And we have moral and ethical codes that we have to adhere to as well as healthcare professionals, which is also important. And it involves positive encouragement. It's about using statements of support and encouraging, giving the patients confidence and the knowledge that we can help them to tackle and solve their problems. And it's as all these different aspects and building blocks come together, that's when the rapport is developed and that therapeutic relationship just gets stronger and becomes more beneficial for both of us. So communication is a clinical skill, and communication is very important because it impacts on the clinical outcome. It's not just the softer skills, it is the key skills. So how do we do this? How as clinicians can we improve our communication to improve our therapeutic relationships with patients? Simple things, key things. It's not about changing our whole approach. It's just about developing different aspects and being aware of things. Open-ended questions. They invite, they entice more information. They can't be answered with a yes or no. It allows the patient to tell their story in their terms, in whatever way they want. So better, worse section. Does bending make you worse? Does walking make you better? They're very biased. They're very loaded or leading. They're already telling the patient the expected response. So they're much more likely to agree with it. Whereas a simple change to that phrase is, what effect does walking have? What happens when you do your exercises? Has anything changed since the last treatment? It's open. They can say positive things, they can say negative things. It's an open question. Affirmations, positive supporting statements that build on the patient's achievements. And that could be something like saying, well done. That could be saying, look at how much movement you've gained from last time. Working with spinal patients, retraction, getting a really good quality end range retraction sometimes takes a bit of time and effort. But when they've got it, I go all gushy. Oh, that's beautiful. Look, that's gorgeous movement. Just keep going. It's positivity. It's building the self-esteem, self-confidence in the patient. And active listening. That is being present. It is being focused. It is being there with the patient one-on-one. And active listening is a skill in itself. It's not just hearing the words, but it's listening for meaning, the intent, the context. It's not just words coming in and words going out, and we'll just do some note-taking in the middle. It's actually processing those words as they're coming through. Active listening involves picking up on emotional cues, so facial expression, tone of voice, so that we can maybe get an insight into how a patient's feeling. Are they expressing some fear, some frustration? Do they have doubt? Are you picking that up from what their face says, not necessarily what their words say? Active listening can involve minimum encourages, and that is to show the patient that you're following their train of thought. You don't want to interrupt them, but you want them to continue, but just to let them know that you're still listening. So that might be eye contact. That might be a nod of the head or a jiggle or a wiggle. It might be the noises. Might be simple statements. Go on. I see. Tell me more. These are all things that are encouraging getting more qualitative information from the patient that we can use for our benefit. Active listening involves the non-verbal cues, body language, spatial awareness, touch, a tap on the shoulder, a tap on the knee. But also these things can't be taken in isolation. So if somebody comes and sits in front of you with their arms crossed in front of their chest, that doesn't necessarily mean to say that they're in a negative space. They might just be cold. Okay, but if somebody sits in front of you with their arms folded across their chest, they're looking away in the corner on the floor, and again, it comes to the gruff expression, that's a greater indicator of negativity. And to be aware of that can very much guide how you then want to approach both questioning and education of that patient. And certainly active listening avoids correction. As soon as we start interrupting patients and talking over the top of them, or not listening to the end of their answer when we think we understand what they're going to say, and let's just jump in with the next question, completely undermines their possession. And it's certainly not in keeping with a collaborative approach. And once we have actively listened and we've taken all that information on board, then that gives the ability for us to reflect back, to paraphrase. And it's almost like the patient tells their story, and then we pick up the interesting bits, those bites, those important bits, and we package it all together, and then we go, bleh, this is a little wee synopsis. This is an overview of what you're saying. And by doing that, that shows that we've listened and we've understood, and it builds trust. It means that which shows that we've understood their perspective, dependent on how we feed that back to the patient. But also it gives the opportunity for clarification. So if there was a really important point that a patient wanted to make, and I've not picked that up, and I've not reflected that back in its importance, a patient can re-emphasize that. If I've picked up something wrong, then they can correct me and adjust the information in a non-confrontational manner. So it's a really, really useful, just packaging it back up and just putting it back to them, just to show them that you've listened, you've understood, and that you're there. So that's a lot of bits and pieces for us all to be thinking about all the time with all our patients, all day, every day. But how do we fit all of that into NDT? Well, quite easily because of the way that our treatment method works. So within the assessment process, using open-ended questions, exploring the patient's beliefs during that history gives us the opportunity to find out what they're thinking, how they're feeling. When we're coming up with a classification and we want to educate, then keeping it simple, keeping it straightforward, using patient-friendly terminology and language that's appropriate for them. During the treatment process, working with the patient so that between us, we can come up with the best exercise for them that is appropriate for them to do, that they're fully engaged with, as well as getting the mechanical and symptomatic response that we want. And that review process, we're constantly reflecting back to the patient reflecting back to us, is that constant feedback loop which embeds trust and develops that therapeutic alliance. And that is only beneficial for all of us. And so small changes in how we communicate, how we ask questions, and how we educate patients can have a big impact on the overall outcome. And that's the greatest opportunity that we all have on a day-to-day basis in our clinical practice. And I know because it's something that I've really come to love in terms of communication and talking to patients, that I've really worked on. And I know that my outcomes with my patients are better, not because of necessarily my understanding of mechanics, anatomy, and literature, but because of my understanding of the patient. So, Gil, over to you.
Thank you,
a double
Jo.
act.
Thank you, Jo, for giving the background and on this topic. So, but what is happening in daily clinic? What is happening in our clinic? Communication is a skill. You just saw the slide of Jo, and we can practice a skill, and you will practice this skill in a minute. So when things go wrong in a relationship, sometimes it's quite obvious, and we can spot it easily. Sometimes it's kind of more hidden, it's maybe more delicate, but we might actually look a little bit deeper. And it's nice to learn from mistakes. It's a common theme. You have to learn from your mistakes. But you are actually in a great position now because you can learn from mistakes of others. That's even nicer, isn't it? Just watching others doing mistakes. So just have a look at some of the mistakes you will just see, or some of the issues, the pitfalls are quite obvious. Some are maybe a little bit more hidden. So you might have seen this guy before, and he is really trying hard.
What makes it worse?
It's already quite bad.
Yeah, but there must be something that hurts even more.
No, throughout the day, it's always there. The pain, walking, sitting, it's bending down. It's really quite bad. I have a lot of problems, a lot of issues.
That doesn't sound good. So what about lying? How's that?
What do you think? What did you spot? What did you didn't like? What happened here? And hey guys, my room in the hotel is a mess because when you stop the cleaning service, they give you a little snack for every day. So I already stopped it for 3 days, so I have enough snacks for you now. So okay, what did you just spot? What happened here? Okay, keep that for later. That doesn't sound good. That was his reaction. Okay, everything hurts. Oh, it doesn't sound good. Well, let's go on. Maybe he can do better.
Lying down, it starts immediately. I get a shooting pain.
I see. Okay.
And there's no relief. I try and swap sides. So I thought maybe sleeping on my side would be better. Going to one side to the other side, but there's just no relief.
That's an important point.
I see. Yeah, I see. Oh, that's an important point. what the heck? Why is that an important point? Maybe it's a good idea to share it with the patient. Not that good. So now you need a person with another colored card next to you. So we need a green one sitting next to a yellow one. If you don't have a green or yellow card in front of you, just decide who's the green and who's the yellow one. Okay? Okay, so if you have a virtual card in front of you. So, okay, all set? Raise your hand. All set? Good, nice. Okay, here's your task. Here's your task. Please stand all up. Stand all up. I want the yellow ones to be the patient. And you're standing next to your clinician and you tell him, everything hurts. You can say it in Czech, actually. Everything hurts. I think it's has something to do with boli, maybe. So, this is the yellow ones, everything hurts. The green ones, you have 60 seconds, 60 seconds to respond to this. How would you respond to this? Keep in mind what you just heard from Joe. So maybe you remember some of the details, or maybe it's just some superficial stuff. So 60 seconds, go ahead. Everything hurts. Okay, and stop it. Stop. Stop it. Stop it. Stop it. Okay. So, I'm sure some of you thought, oh, that was a bloody good response. So who wants to share how his or her neighbor responded? Give me a good response. What was a good response? Okay, here's a little dessert. What was a good response? Go ahead. What did your neighbor say? And you said, oh, that was bloody good. I will keep that in mind for the future. Anybody? Don't be shy. Okay? Sorry? Everything hurts? Me too? So, how about using a simple practice like just paraphrasing? There's no pain-free situation during the day. So you give the patient the opportunity to react on that, to think about it. Is there no pain-free situation during the day? Maybe you say, oh, no, it's not like that, but when I do this and this, then it hurts. Okay, that sounds different. Or maybe thanks a lot for sharing this. I understand this is really bothering you. Empathy. I understand it. I'm hearing you. I'm listening to that. This helps me to understand the situation better. Hey, there was some value in this statement. You are hurt, and it helps me to understand you better. And let's go on, and this is really bothering you. Would you mind if we check some movements or positions that might give you some relief? So that leads on to some kind of, how can we go on with that? So we hear the patient with empathy. We might paraphrase so the patient can react.
Moving helps. That's better than just sitting around and doing nothing.
What's that? It's so suggestive. Hey, moving is great. It's better than just sitting around. It can even get worse.
So standing is better. And walking, of course. And I conclude that sitting and bending makes a difference. Yeah, I don't know about that.
Of course, that's a bit over the top. But yeah, we are biased. We as clinicians, as physios, we are biased. We are biased towards movement, towards exercise. Stanner showed in his qualitative research that physios, as soon as a patient enters the room, we think, yes, this patient has to move. Exercise is a great thing. So we have our bias towards exercise in a positive way. Okay. And we all have our own biases. You might have your own bias. Not that maybe hidden or not that obvious, but yeah. And what we say to patients can have a lasting impact. We know that when we talk to patients, how important it is to use the right words. We know that depending on how we, for example, how we explain a condition, it might make a difference. If the patient decides, oh yes, I can go on with conservative treatment, I can fix that by myself, or I need surgery. There's good research. It's just using the wrong words, or words that actually really foster this, they push this forward, this idea. But we have to be careful. Martin just recently showed, yes, it's great to use diagnostic labels, non-specific terminology compared to specific labels. Diagnostic labels, it's really great. Patients think, yeah, I can manage this by myself. I might not need surgery. I have a better prognosis. But he also showed you cannot just tell somebody, that's just back pain, back strain. The patients, they don't want that wishy-washy stuff. So they are less satisfied. When we give them non-specific labels, they are less satisfied. They have a better prognosis and it's more positive, everything, but they are less satisfied. So we have to take care to give them some good explanations. When we talk about our directional preference, yeah, to ask the patient, what do you think? Why does the exercise help? And then we take it from there. Instead of saying, oh yeah, it's nice, just go on and do it. It helps.
Imaging, yeah, it shows a disc prolapse.
All of us have heard this statement in their career. 100,000 times, maybe Hans 1 million times. Beware. And here's the next task for you. Please stand up. Now we have the yellow ones, the green ones are now the patient. And here's the statement. Joe, the MRI shows a big tear in my meniscus. Okay? Go ahead. The MRI shows a big tear in my meniscus. You have 60 seconds. How do you respond to that? And let's clarify, the patient tells you this at the end of the history. So before we turn the page and we do the clinical exam, the patient tells you, oh, I have a big tear in my meniscus. The imaging shows. Go ahead, 60 seconds. We started 10 minutes later. 10 minutes later? I think so. We are good. Yeah, we are okay, fine. Yeah, we started 10 minutes later. So it is until 5 after. So we still have, quite a bit of, actually 15 minutes. That's good. Only a few slides left. It's okay. It's good. Okay, and stop it. So, okay, thank you. So here, that was a task. the imaging the MRI shows a big tear in my meniscus, and that patient tells us at the end of the history when we have that line imaging, yes, no, okay, on our assessment form. Question is, how do we respond? This time, me too doesn't work. Sorry. Okay, what was a good response? What was a good response? Seriously. But okay, you give it to your neighbor, of course. So say it again. What do you think about this? So your neighbor gets it. Thank you. And yeah, what do you think? What's wrong? And maybe a good start is, what did the doctor explain to you? Because we also know from research and from clinical practice that there's hardly any worse thing than if two experts tell you exactly the opposite. So we might start with some, oh yeah, it's no problem at all. But a doctor explained, oh, you need surgery. Okay, so what did the doctor explain? We take it from there. And then, what do you think about this? So well done, Anjay. What do you think about this? What's your take on this? Maybe the patient is not too concerned. Yeah, I've heard about every second football player has this or something. Or I always recommend just hold back a bit, and we come back to this. First, we have to do some tests. And that fits with Hans' topic. If Hans gets a patient, and at the end of the history, the patient tells, yeah, I have this disc prolapse. And Hans is so super confident. Yeah, research tells us blah, blah, blah. And then he does the exam and he finds, oh, damn, it is. I can't do anything at this point. So it is actually a radicular syndrome without directional preference. And it is really this irritated nerve root, maybe high reactivity and all this. So wait until the clinical exam.
Studies show it's mostly coincidence. It doesn't play a role.
Not a good idea in some cases.
Plays a role for me.
It plays a role for me. So yeah, it plays a role for me. Maybe studies show it doesn't play a role. Yeah, it plays a role for me. So I had this stupid pain. Now I have an explanation, and you are telling me it doesn't play a role? What the heck? Wait before we've done the clinical exam. It makes it much easier to talk about prognosis, and so when we see maybe some positive response. And I think some of you know the RULE acronym. And actually the clinician at this point, he couldn't resist the R. And the R means resist the writing reflex. He immediately thought, I have to correct this thought, this assumption. I have to correct it. I said, oh, no. Most studies show blah, blah, blah. So, but instead of just immediately correcting our patient, just, okay, stop. And Joe was talking about this. Stop correcting. Just listen first. And instead of correcting our patient, we just, okay, let's listen and explain, why do you think this is a bad thing or whatever? And not immediately say, oh, no, that's wrong. That's wrong. Stop this exercise. Never seen such a bloody stupid exercise. So, and there's more in this acronym than the R. We have understand your patient. Understand, where are you coming from? What is your story? And listen again with empathy. The clinician you just saw, it didn't show any empathy actually. So he did a lousy job. That was not empathetic at all. And we physios, we McKenzie guys, we should be good at empowering our patients, not just telling them. It might be a good idea to ask, hey, Joe, out of all these exercises we just did, which one would you do at home? Oh, maybe I would do this. Why? Oh, because it's so sexy. No, because maybe my leg pain disappeared when I did that. So yeah, good idea. We empower our patients. We talked a lot about how we talk to our patients, we listen to our patients, but at the end, you should never forget, rarely it's about what we said. It's much more about how people feel when they leave us. That is what they might remember. Thanks a lot. That's it. And So if you're interested in the references of our presentation, you can just scan this QR code. And we are open for questions. So if any questions, just go on with them. And we are also still here after the presentation, so you can still approach us. Andre? Awesome.
Maybe if you don't feel like that the MDT questionnaire is kind of leading us off or out or from the like active listening, and so because if we wouldn't have it, we would focus more on the patient, and now we focus on the paper like more. Like,
so you think the assessment form is kind of distracting us from the patient?
No.
Actually, it gives us a nice guidance. It doesn't tell us that that's not a dogmatic form we have to fill, and we don't have to go through every single question. It gives us a nice guideline here. So, and I wouldn't say, and it gives us a nice opportunity to write it down and to note it. And what I always do is I tell my patient at the beginning of the exam, I tell them, oh, I will take some notes. Is that okay for you? And there is a second advantage with this. When I do this, and patients, they don't stop talking. You all know there are some patients that never stop talking. And you look at the watch, damn, 10 minutes, all this. So how can we stop them? I can say, because we agreed at the beginning that I will take notes. Just wait a minute. I will just reframe this, or I'll just rewrite this. So we have to kind of interrupt the patient in a nice way with because we discussed this and I take notes, or because we only have 10 minutes. You want to add something?
I don't use the form when I'm assessing the patient. I fill the form in. Sorry, is that better? I don't use a form during my assessment. I have a piece of paper there that if I need to remember something specific, but I can close my eyes and I can visualize that form. I know exactly how the questioning is going to go, but by not sticking to the rigid, I'm going to ask this question, and then this question. I'm there, I'm listening. The patient can go within parameters can go and give me whatever information that they want at whatever time, in whatever order. And then afterwards I go to the form, and I've already then, because I've reflected back to the patient, picked out those salient bits, summarized it, packaged it up and reflected it back. Then it takes me 2 minutes to fill in the form because it's circle here, and it's all done. So I think using the form, it's not there to restrict, but it's there as a guide, and it's a very useful guide because it facilitates your clinical reasoning and your decision making. But that can be visual in your head, it can be there on your piece of paper, it can be there on a clipboard, but you have to be aware of the interruption that may have on your interaction with the patient. Take that on an individual basis and how you feel comfortable.
So you can follow the strict German way with the form, or you can go for the soft, creative UK way. Love it. Any other questions? Okay. If not, we are still here after the presentation. And so, yeah, have a nice evening and stay healthy.
Thank you.